Well, good evening, everybody. Really wonderful to welcome the members of the 1811 Society and the Phillips Society. It really is wonderful just to see so many familiar faces from years past. I really want to thank you for your tenacity and making it from the lobby up to the first floor. Who knew that a broken escalator could have such an effect? Anyway, thanks for making it up here. I have to say that this symposium is really one of my favorite evenings of the year, because it really allows us an opportunity to sit and discuss with really many of our most loyal donors some of the most sort of pressing health issues of the day. And what I really enjoy about this particular group are the questions that come sort of after the presentation. Really, the insights from the audience really cast a new light and are really informative for all of us. And I'm really especially grateful to this group because I think of all of our donors, you really do understand the importance of unrestricted giving to the hospital. It's really humbling to us, knowing that you trust us to the extent that you know that and feel that leadership knows what the needs are, whether it be responding to an opportunity, whether it's responding to a crisis. But these funds are so vitally important, and the MGH fund has been a striking success as a catalyst for launching a new, really, life-saving programs and allowing us to recruit really sort of the best and the brightest scientists and clinicians, which allow us to stay at the forefront. And it really allows the MGH to remain strong in the decades to come. And that's why I'm really pleased just to announce that just in this past year, fiscal year 23, the MGH raised over $12 million. And what's even more remarkable is through the course of the campaign, we've actually broken our goal that we set for the money raised through the MGH fund. So we've broken the $100 million barrier. And so anyway, you deserve a round of applause. So please give it a So I'd just like to give you two examples of the way the MGH fund works. When the pandemic hit, there were any one of a number of needs that we were faced. And frankly, not knowing that the pandemic was coming, these weren't not things that we had sort of put into the budget. So what the MGH fund allowed us to do was, if you can think back to the pandemic, at the very beginning, and it's hard to believe that now, given the ready availability of these home tests that you can get in any drugstore, there was no testing. The way it initially worked out was that we would get a sample, basically a nasal swab. We would FedEx it down to Atlanta, and then 5 or 6 days later, we would get a result. Now, that was helpful for epidemiologic purposes, but in terms of trying to figure out sort of how to treat a patient, and David Lewis of our pathology department came to Peter Slavin almost immediately and said, boy, if we had the following funds and the following equipment, I think we could create our own test at the MGH. And within 2 weeks, we were testing at the MGH. That was made possible by these unrestricted funds from the MGH fund. The other thing it allowed us to do was, once we recognized that communities for which we feel responsible, Chelsea and Revere, recognizing that there was really an inequitable distribution and availability of vaccines in those areas, the MGH fund helped to launch mobile vans and clinics, and preferentially sending vaccines to those communities, actually to meet what was sort of an inequitable approach, to this pandemic. And one other example is that the MGH Fund has allowed us to develop a comprehensive sickle cell disease treatment center. Not only is it the first center like this in Boston, it's actually one of the first centers in the United States, and has attracted, that seed funding has actually attracted support from a number of donors and pharmaceutical companies, but it was the MGH Fund, seed fund, which allowed this to happen. So, these examples really illustrate just a fraction of the MGH's fund's impact. And again, we're just incredibly grateful for the trust that you place in us by giving us this unrestricted sort of giving support. Now, tonight, you're going to have the opportunity to meet several of my colleagues, Dr. Douglas Micalizzi and Dr. Cesar Castro. And both are leading experts in the area of the field of cancer research. And they'll be sharing really what I would say is inspiring work in detail. After they make their presentations, we'll have time for a question and answer period. And if history is any guide, we're not going to be able to get to all of the questions. But that's one of the reasons for the reception afterwards. That they'll be circulating around, and you'll have a chance for a one-on-one tutorial on the question of your choice. But before we kick off with their presentations, I want to introduce our first speaker. And it really is a true privilege for me to introduce Dr. Marcela del Carmen tonight. And Dr. del Carmen is Mass General's new president. Now, Dr. Brown, whom you have heard before, has transitioned into a new expanded role overseeing academic activities between the Brigham and the MGH. And we are so fortunate that Dr. Carmen has stepped in and deservedly stepped in as president. Dr. Del Carmen has spent most of her career at the MGH, and she's a brilliant researcher. She's an extraordinarily gifted surgeon. She's a respected leader, having been the president of the Mass General Physicians Organization. She's a wonderful partner to the development office. But one of the things is that Dr. Del Carmen is really known at the MGH as the doctor's doctor. And that's really quite a tribute. And Marcela, we are so thrilled that you're with us tonight. So
thank you, Rick. Thank you very, very much for your kind comments. Thank you for inviting me to be part of this incredible event. I have to say I've been looking forward to it as soon as I heard that I was going to be able to step into David's shoes. They're big shoes to fill. He's been an incredible partner in my work leading the physicians organization, and will remain a partner as we go through the transformation and integration process of becoming a single healthcare system. As Britt said, I'm a GYN oncologist by training, so my clinical life is spent taking care of women with gynecological cancers. And I want to tell you that one of the things that has been an incredible lifetime career opportunity for me has been to partner with people like David Brown and Britt Nicholson. But today I feel like a new partnership begins for me, and it's a partnership with each of you. My role as president of the MGH is to make sure that we steward our resources so that we're here 20 years from now, 200 years from now, 600 years from now, doing the kind of work in providing care for our patients that has been transformative. We are at a critical moment in the academic vision of all of our hospitals as we move from the pandemic, and we have to reinvent how we provide clinical care, how we innovate in research, and how we actually invest in education. The world is changing, and we have to change with the world, right? We can no longer practice medicine with the structures that we had in place 20, 30, 40 years ago. So I'm really excited. I think the future has never looked brighter. The possibilities are unimaginable. When I think of my career trajectory as a gynecologic oncologist, when I started my career in 2002 as a faculty member, seeing a patient with gynecological cancers often meant that you could palliate her cancer, but that cure was not an option. Today, I can look at women in the eye with ovarian cancer and tell them they will survive. And that has been because of the innovation that funding like the type of funding that you provide actually allows us to broker through research and innovation. You know, Britt said it well, I think. The trust that you put in us in giving us unrestricted funding allows us to use that funding to really be creative and support incredible clinicians and scientists like the two speakers we have today. And you'll see how the work that they've led is transforming the way that we care for patients. As a gynecologic oncologist, it has always been my privilege and proud moment that every patient that walks through our cancer center is afforded the best treatment with regards to standard of care, but also the best supportive care and the best experimental research level care that we can provide them. And that will remain the case thanks to your generosity and your trust in us in being able to harness and use your support over the next several years. I think, you know, when I look at the future of cancer, it's going to be early detection and screening, and you'll get to hear some of that work from one of the national leading figures in that research space, Dr. Micalizzi, as Britt said, will give you a purview of the work that he's been leading. And you'll hear about some of the innovation in my own field in gynecological cancer from Dr. Cesar Castro. The future, again, has never been brighter. As we look to the future, we look at new space. The Philip and Susan Reagan building will house cancer, as well as the Heart Center. And that's place, the space itself, the flexibility to really build community and team medicine. You know, the way that we care for patients today is very interdisciplinary. We are very well poised to do that work like nobody else. Because we are a general hospital, and as we are seeing more patients survive cancers, we have to deal with some of the side effects of treatment and also survivorship. We're well poised to do that because we're a general hospital with great cancer care. We're not a cancer center alone, and I would argue that you miss out on opportunities to actually take care of the entire patient and the entire journey of a lifetime, but that we're not going to have those challenges because of the fact that we are a general hospital. The new building is a reassuring symbol, in my opinion, of our commitment to clinical care, to innovation, to training the next generation of clinicians and to the communities that we serve. Thank you again for your trust. I look forward to this new partnership that for me starts today with each of you. You have my commitment that I will be a great steward and will be a responsible steward of your support for clinical work. I want to now take a few minutes to introduce Dr. Douglas Micalizzi, who's going to be talking to you about the research that he leads. He's the clinical director of the Cancer Early Detection and Diagnostic Clinic at Mass General. So, Douglas, thank you.
We have the.
Is it underneath?
Perfect. All right. Well, fantastic. Well, thank you all for the opportunity to be with you tonight. It is absolutely my great honor to be at such a wonderful event and to meet all of you. I look forward to lots of good questions and discussions after our presentations today. I'm also honored to share the stage with my colleagues and in particular Dr. Castro, and look forward to his talk too. And so want to tell you a bit about our work at Mass General looking and working on early detection in cancer. And so without going into a lot of detail, I think many of us realize there are different types of cancer. There are also different characteristics of the cancers that we diagnose. And one of the most important aspects of cancer diagnosis is the stage at which it is diagnosed. Early stage cancers are cancers that have treatments that often can lead to cure, and the outcomes and prognosis are quite good. But the diagnosis of more advanced stage cancers are cancers that are challenging to treat. And while we've made a lot of advances in that treatment, many of the real advanced cancers are where the cancer mortality lies. And so one of the key things that I think we can look at going forward in terms of moving the needle, actually making changes in cancer mortality across the country, are really about trying to detect cancers earlier at a time when they're more treatable and more curable. And so I can show this in the situation of breast cancer. This is the area of cancer that I also treat. And you can see with this figure here that the breast cancers that are diagnosed at the earliest stages, stage 1, the overall prognosis is excellent. At 5 years, 98–99% of those women will be alive. However, if they're diagnosed at the latest stage, stage 4, only about 30% of those women will be alive at 5 years. And so this really serves as the basis of the idea then of being able to screen for cancers and detect them at a time when they're more treatable. And this serves as the basis of much of our national programs to advance cancer screening. So the screening mammography with breast cancer, screening for colon cancer, lung cancer, and cervical cancer. But if we look at the number of cancer deaths and what those cancers are attributed to, we see that almost 80% of the deaths due to cancer in the US are those without the standard screening. And so this is an area that I think is ripe for improvements and advances going forward. And with those, we can really make a difference in terms of cancer mortality. And so what are those ways that we can move forward in this? I think there are multiple aspects to this. One is improving the uptake of the current cancer screening, the screening that we already know is effective. But then there's also the public health measures that we can take to encourage and decrease cancer risk. So encourage lifestyle modifications or other changes that can reduce cancer risk. But today I'll talk more about the last 2 points here. One is, how do we identify those individuals at increased risk of cancer? And then how do we develop new methods to detect this cancer early in those cancers? And so this is really the paradigm that we're working on. If we take the population across the US and we are able to risk assess that population and then risk stratify. So what this means is take those individuals and group them into different levels of risk. So some individuals will be at lower risk. Those individuals may not need as intensive screening. There are going to be most of the individuals who are at average risk and may need a certain level of screening. But what I think we can really do is identify those at the highest risk. And for those, we can intensify screening, and those even at the highest risk include things like prophylactic surgeries or very intensified screening. And so this is the idea of taking a population of individuals, assessing their risk, stratifying that, and then tailoring the cancer screening to that. And so to do that, we need improvements in a number of different aspects. One, we need better algorithms and better ways to assess cancer risk. And this means identifying new risk factors. I mean, this area is ripe for real advancements based on the development of artificial intelligence and machine learning that's going to allow us to integrate this huge amount of information that then can hopefully predict cancer risk. We also are looking at novel ways to assess cancer risk. Much of our risk assessment these days is static, meaning that it's based on risk factors that are established and not changing. But what if we could have cancer risk assessments that are dynamic, meaning it gives you an estimation of your risk of cancer over the next year or the next 5 years instead of over a lifetime? Then we can intensify screening within a year or within the next 5 years. In addition to that, we need improvements in cancer screening. So this will come from novel imaging and improvements on our imaging, whether it's MRI technology or other modalities, or maybe new tracers that are being developed that can identify these markers in this idea of cancer. But what I want to talk a little bit more about today are some of the blood-based cancer screening tests that are being developed. And so these are exciting, but we're also cautiously optimistic with them. And these tests can be both single or multi-cancer early detection tests. And I'll talk more about these. But while cancer screening is, as I emphasized, so important, so is the diagnosis of cancer. And this is really a vulnerable time. So this is looking at that time from when a symptom or a sign of cancer is detected, and then determining the diagnosis of what that cancer may be. And so this is a particularly vulnerable time for individuals as they go along a cancer journey. And so this is also an aspect that we've been very interested in at MGH and looking at ways to improve this. Because there are currently, barriers and obstacles in this period of time. For example, what are those delays that can lead to a delay in diagnosis and ultimately a delay in treatment? They can be access delays. They can be diagnostic delays, not having the right tests. They can also be treatment delays. And these are things that we're looking to try and minimize. In addition, there are financial barriers, there are logistical barriers, and psychosocial barriers that contribute to the diagnosis and potentially can be improved and then therefore lead to a more expedited diagnosis and ultimately treatment. And so this led us to proceed to develop a clinic in a center that is really focused on this. It's the Early Cancer or Cancer Early Detection and Diagnostics Clinic. Our clinic is located in Waltham at the MGH site there. And we look at this as a one-stop shop for patients at risk for cancer or with a concern for cancer. And so we have developed a really incredible team, and this is really just a part of that team. We have a number of providers across a variety of different disease centers and expertise. We have nurse practitioners. We have a robust navigation of nurses and patient navigators who really provide the support for these patients who are coming in concerned about cancer or concerned that they might have cancer. We also have had incredible support from the administration, and this has been really a vision of the cancer center leaders at MGH. We have a robust research team that is growing and expanding to develop the next generation of clinical trials and research that's needed. We also have collaborations across MGH, whether it's lifestyle medicine or imaging teams. We have collaborations with industry, and also, obviously, we have a lot of support from folks like you who are willing to donate and support our work here. And so what is it that we offer in this clinic? There's a couple of different categories here. We offer a cancer risk assessment. So this is really to assess cancer risk based on genetic features, based on family history, based on personal or occupational risk factors. And here we can offer cancer screenings, obviously the standard cancer screenings that are well supported in their work and improvements, but we can also offer some of these more novel screening tests. We offer genetic testing and also participation in research trials. In addition, getting to that other aspect of cancer, and particularly the diagnostic aspect, we see patients who have a concern for malignancy and really work up that diagnostic process. And then we work to get them to the specialty cancer clinic to get them that care and treatment as soon as possible. We also have incorporated our pulmonary nodule clinic into the early detection center. And this is a real multidisciplinary clinic that assesses each pulmonary nodule that we see and determines what is the appropriate screening going forward and when is the right time that maybe other interventions are necessary. But I want to talk a little bit about the multi-cancer early detection test because these are making a lot of news. And I think this is an important thing to begin to think about and how to implement. So these multi-cancer early detection tests are blood-based cancer tests. What do they detect? They detect signals for cancer within the bloodstream. Many of these look at DNA or patterns of what are called methylation or proteins in the blood that are signs of cancer. And what's also exciting about some of these signals of cancer that can be detected in the blood is not only do they give you a positive potential for cancer or not, but also they can give an idea of where that cancer might be originated from. And that's really critical to be able to then work up this. And so these are early tests. This is early times for this. These are the tests that are available are commercially available, in particular one, but not FDA approved yet, not been paid for by insurance. But this is really the first generation and what I see as the next generation of cancer screening here. And so what are some of the key characteristics of these tests? So importantly, this is a test that is not perfect. It's not a diagnostic test. It is still a screening test. So if we take 100 individuals and who are all over 50, apply this test or give them this test, which is simply a blood collection, about 1 to 1.5% of individuals will test positive, have a cancer signal detected. And the specificity, meaning how good the test is, at detecting actually people without cancer, it's quite good. That's that 99.5%. But the question becomes, okay, how good is it at detecting cancer? Only about 40% of those tests that are positive actually have a cancer that's detected. We're still learning about this. We don't know if we're detecting signals before they're evident by other methods, or if these are true false positives. And so this is an area certainly of future interest and need. But really the critical thing here is, are these tests detecting early cancer at a time when we can intervene and make a difference, cure more individuals with cancer? And that's still to be determined, but we are encouraged by some of the signs of these new tests, including the spectrum of cancers that can be detected with these tests, as you can see from this diagram. So what do we still need to learn about these tests? We need to know, what is the true benefit? Are we detecting cancers early enough to intervene? Who should be getting tested? Right now, the implementation of this is unfortunately, not probably the best way to do this, and we need to work on this. This is based on, individuals who are able and know about the test and are able to pay for the test. And so we need to identify individuals, as I was saying, with an increased risk who maybe benefit this the most. We also don't know how often to test. Is it a yearly test? Is it every other year? Is it every 6 months? And what are those risks associated with the test? So false positives, false negatives, the anxiety that can be caused by these tests, the unnecessary other tests and biopsies that are needed, and of course, most importantly, the cost too. So we're really interested in analyzing and looking at this from a wide variety of angles within our clinic. And so in our research that we're doing, all patients who come into our clinic, we're asking to participate, if they're willing, a clinical trial or a clinical research study where we're asking them to complete a survey and contribute a biospecimen to be able to understand better the patients who are coming in and understanding hopefully better how to screen. We also are really excited about some of our imaging trials, looking at ways to improve the imaging techniques and the screening, and of course the blood-based screening across a variety of different aspects. And actually you'll hear from Dr. Castro of some of his work in this area. We're also very interested in special populations who may be at increased risk. Firefighters, veterans, or others who have occupational risks, and we're working with Homebase and other organizations to identify these. And so how is it that we really transform early detection? This needs to be a multidisciplinary approach. We know that primary care physicians are critical in this. The community health that's already established. We need epidemiologists and bioinformatics folks who are understanding the numbers and the risks. We need folks who are interested in lifestyle medicine. How do we motivate people to make changes in their life that then can affect their cancer risk? We need oncologists and research scientists, and of course, generous donors who are willing to trust us with that, that support, which allows us to then look at things maybe different than a grant that is government funded or a company that has a financial interest in this. And so this is where we see early detection really centered. And we hope and are really developing our clinic with this idea that we can work on a number of different aspects of early detection, including improving compliance with current screening, developing these new ways and methods to determine cancer risk, to develop these new cancer screening technologies and implement them, to integrate the counseling and the risk-reducing lifestyle modifications, and also to support individuals when they're provided with information about their cancer risk. This can be a very anxiety-producing endeavor. And we also are working to expedite then the workup of these findings. And so this has really been the basis of our clinic. And we've been really excited at the past year and a half that our clinic has been started. This is still a relatively new endeavor, and we are just so excited to be a part of it. And so with that, I'll leave you just with a little bit of information about the clinic and the website and our contact information from myself, and then also Dr. Alicia Sequest, who is our program director. And really appreciate your time and look forward to the questions and also discussions going forward. And now I'll have Dr. Castro come up for his presentation.
Okay. Good. All right. Thank you, Doctor. Thank you, everyone, for the invitation today. I'm Cesar Castro. I am the director of the Gynecologic Oncology Program here at the Mass General Cancer Center. And I'll be discussing the early detection of gynecologic cancers. And for the sake of time, I'll be a little bit more specific and select one subtype. I'll be focusing on ovarian cancer. Not to say, though, that our stellar investigators and clinicians in the gynecologic oncology space, they are invested in treating and understanding cancers of the uterus, cervical cancer, vaginal cancers, vulvar cancers. Okay, this is just kind of one example. I'd be remiss if I could not highlight my strong leadership in the form of Drs. Sarah Buberhan and Amy Bragar, who are co-clinical directors here at the MGH Cancer Center's program. Dr. Bragg is also the director of the division, director within the OB/GYN department. And Dr. Angela Russo is the director of the Gynecologic Radiation Oncology. So I'd love to start with the case. And it doesn't comprise a particular patient, for obvious privacy reasons, but it is a combination of actual patients that I've treated over the years. So this is a young 32-year-old female who worked as a high-performing corporate attorney. She's also an author inside, taking care of her 6-year-old son. As a single mother, it was obvious she had 36 hours in her day. Her mother died from ovarian cancer 30 years prior. And upon genetic testing, this patient was found to have a BRCA1 mutation. So she was determined not to have cancer derail her identity as a mother, as a sister, as an author, as an attorney. So she pursued annual transvaginal ultrasound and CA-125 testing. Then in January of 2023, she began to experience mild abdominal discomfort. She attributed to routine gastrointestinal issues. After all, she had a normal CA-125, a normal ultrasound not long prior. She was too busy, unfortunately, with life to seek immediate medical attention. And then the pain became unrelenting. She was diagnosed eventually with stage 3C high-grade serous ovarian cancer. Now, it's not an uncommon diagnosis, and we see that. It's also, unfortunately, one of the most aggressive subtypes. The field has made significant inroads, I would say, with respects to the outcomes with the cancer, but certainly more can be made. And the impact, particularly with survival, has only been modest. So our scientific understanding of this cancer, I would say, is growing, but maybe more linearly and not yet exponentially. And so reasons for the limited understanding of some of the modest outcomes, particularly with this aggressive subtype, I would say stems from an older kind of paradigm of how we approach such cancers, how we investigated such cancers. And this occurs when biologists or chemists, engineers, oncologists, surgeons, etc., they investigate their own work. And the outcomes are more specific to their unique kind of field. What we haven't seen here and lacking is the cross-pollination, right, of the outcomes. We don't have the synergies, okay, of these disciplines. And that's the secret sauce, okay? It's about cross-pollination. And so fortunately, the Mass General Hospital has long subscribed to this notion that concerted and collaborative endeavors across these disciplines actually lead to greater innovations. What makes the MGH program, I would say, special is this really multimodal approach to things and solutions. We tap into the various resources that we can leverage across the hospital, not just within our program. So the panacea won't just be a radiation one or a surgical one, but be a collaborative one that embraces the various facets of understanding, really about offering complementary insights where the whole is greater than some of its parts. And so we are fortunate to really tap into expertise and resources in advancing surgical practices, new ways to analyze specimens, understanding the deep dive kind of wiring of these tumors through genomics, creating and advancing forward-thinking translational trials, and even new imaging modalities that don't even look at the tumor itself, but the environment, kind of the interaction tumor and its environment. So with respects to the earlier detection of ovarian cancer, this MGH way is needed now more than ever. That's because the challenge and the sad reality is that about 75%, or a little more, of women with a new diagnosis of ovarian cancer present with stage 3 or 4 disease. Okay. That's advanced disease. How demoralizing and scary must it have been for our patient? She knew she was at risk. She did the testing. And now she has this cancer that's developed and it's incurable. Treatable, but incurable. Her career ambitions, her endeavors for her son have to step aside for her new identity as a cancer patient. But with every challenge, there is opportunity, and I truly believe that. In the ovarian cancer realm, we've actually found some solace in our increasing appreciation for the origins of ovarian cancer. Very astute pathologists and other investigators have identified the fallopian tube as ground zero for ovarian cancer. And they've noted this doesn't go from 0 to 60 in just a month. It takes about 7 years for this early lesion, these early lesions along the fallopian tube that develop abnormalities, in particular in P53, that then themselves beget cancers, not invasive yet. So we call these serous tubule intraepithelial carcinomas, or STICs. It's almost like the DCIS equivalent of breast cancer. Then eventually they become cancerous and invasive. But I want you to pay close attention to the anatomical relationships between the fallopian tube and the ovary. Okay, you can envision those cells passively just shedding, okay, not actively, just passively, and seeding the ovary. And also, the lumen, the tunnel within that fallopian tube, also opens to the abdominal cavity. So you can see those cells also passively seeded. So you miss these signals. You miss the signals where in other cancers, tumor has to invade critical structures, probably with millions of nerve cells. And so one would get those early SOS signals, okay, that something's happening early on. But here, it's not so, it's a little too late. And so with the 7-year head start, would it be unreasonable for one to find optimism and, okay, let's just use our known modalities of blood tests, CA-125, and the transvaginal ultrasound, and that could be our solution. However, unfortunately, this was reported in 2021, there's a large trial out of the UK with more than 200,000 women who, over a 4-year period, were recruited to undergo, and we didn't know their risk factor then, they needed the clinic, to undergo either CA-125 and or transvaginal ultrasound testing, or no screening. So after about a 15+ year follow-up period, the unfortunate was that there was no moving of the needle. There was no survival benefit. But again, I see opportunities, right? And I think what it's given the field permission to move beyond, or in addition to CA-125 and transvaginal ultrasound. And I hope to convince you today the use of novel strategies, including the liquid biopsy. So there's an old mantra in oncology: tissue is the issue. And it recognizes the high premium that we place on securing enough tissue so we can render an accurate diagnosis to allow the pathologist ample time and space. But in reality, there's a spectrum, right? So at the bottom, you see the surgically acquired tissue, gives you ample number of cells. And in the screening platform, not very feasible to do serial surgery. No IRB. I'm an IRB chair. Would not approve that. But at the other end of the spectrum is the liquid biopsy. And it comprises some common vital fluids, such as blood, urine, mucus, sputum, etc. And so, just for brevity, I will focus on blood, although we are exploring the other options. And so here, it's very easy to do serial testing, but we have to overcome its kryptonite, it's essentially the low cell numbers. Now, the liquid biopsy space is not new, and indeed there are subsets that are well-traveled and others where not traveled at all. And so with respect to the liquid biopsy in blood, there are circulating tumor cells. These are just legitimate fragments of cancer cells in the bloodstream. That's certainly not new. It was first described in 1869. Then we also have our testing for the blueprints of cancers, the DNA, the RNA. It's complementary information for sure, but sometimes those readouts more reflect dying or dead cancer cells, and not actively viable cells. And so the work that our group and our program works in is we look at other biomarkers, in particular extracellular vesicles, EVs, for those of you know. And these are essentially miniaturized shuttles that are released by every cell in our body, cancer or non-cancerous, but disproportionately more so by cancerous cells. And so in this example, here's a genuine advanced imaging example of a cancer cell in A. And you see there that that cell is kind of decorated by various particles. You zoom in and B, and these particles are actually vesicles. And these extracellular vesicles, the diameter of these vesicles are 30 to 200 nanometers wide. So just to give you perspective, okay, a nanometer is 1/billionth of a meter. Okay. One hair follicle is 100,000 nanometers wide. Right, so we're looking at particles 30 to 200 nanometers. So that's the challenge, but the opportunity for MGH. So let's get back to this story, respects to the fallopian tube. So we acknowledge that the cells along the fallopian tube transform over a certain amount of time, but no imaging modality now, unless we get into Star Trek, down the line, we'll be able to identify those cells. It's too small, no ultrasound, no MRIs, etc. But what we proposed was actually taking advantage of these extracellular vesicles that are released from these cells. And so each cell will release 10,000 of these vesicles in a 24-hour period. And we know that about a centimeter tumor has about 100 million cells. So over a 24-hour period, we'll be able to capture 1 trillion of these EVs. And with blood, we can do that very soon. So that's the hope. And we did work, and this was in part by the National Cancer Institute's Liquid Biopsy Consortium. So a group of various institutions throughout the US, privileged to be on their steering committee. And we identified a signature, so just some EV kind of readouts, that we were able to identify early ovarian cancer, starting with Petri dish, then proceeding to a mouse model. It's an advanced mouse model of ovarian cancer derived from its fallopian tube, as realistic as we can, and then also in the blood of patients who were already diagnosed over different stages. We're going to see that, and we're ready to scale that partial trials. We were happy to have the covering for our work. So we have our own mantra. We need to go small to detect small, right? And so we, over the years, through my colleagues in the Cancer Center and colleagues at the Center for Systems Biology, Weisletter, Hoppe Lee, and we've been able to really leverage the various fundamental imaging and sensing principles, magnetism, fluorescence, resonance, holography, to identify these cells or particles or just small neuroaspirates, to really move beyond the large surgical specimens. And over the past 10 years, we've been successful with respect to our extracellular vesicle platforms. So now we can even remove the extracellular vesicles from blood using special filter that we developed an approach to use sound waves, just pulling them out of the blood. We've got technology, this is all MGH technologies to identify the blueprints, whether the RNA or the DNA. We have high-tech platforms, but more recently, we also developed point-of-care testing with the eventual downstream hope that the end user will reside at home. And he or she will be able to test. And so what I want to propose to you, Steve, is that there's not one winner take all. I think it's very important just that really the solution is going to be multi-parametric. I'm giving you one example of one biomarker, but I'm not naive to say that that's the only solution. Biology, physiology is very complicated. One can envision the use of these extracellular vesicles along with the CM25, along with the ultrasound in individuals without known cancer or at risk. But also, why don't we move the needle and expand its application and identify earlier detection of recurrence in individuals that just have a known cancer, finish their treatment, for individuals that are now in surveillance, no known evidence by conventional imaging, but a way where we can detect early recurrence. Particularly in the gynecology space, there are certain therapies, oral therapies that we use. There's no free lunch in medicine. They can be fairly toxic at times. And so it kind of justifies the risk benefit if we see some of these readouts still showing indeed no cancer. That's the concept of minimal residual disease. Hopefully that's another symposium that we might go to. So ultimately, the ingredients that I've gleaned over the past 15 years now here at MGH is really that it's the seamless integration between innovation, teamwork, funding, and it's highly inclusive of generous funding as well, generous donations, and translational trials, so that we can bridge that divide between the bench and the best. Thank you for your attention.
So as I promised, we have time for some questions, and just to let you know, just raise your hand, and we have staff that'll be walking around with the microphones. As I call on you, they'll bring the microphone to you, and then you can go ahead and ask the question. In terms of sort of the question, anything that was sort of mentioned in the lecture this evening, anything broadly on a cancer topic, or anything of interest even about the hospital at large, we've got it well covered. So any questions? Lauren, so.
Dr. Micalizzi, you mentioned the out-of-pocket costing for the testing, about what's
You were, sorry.
the out-of-pocket.
Absolutely. So right now, the test that's currently available commercially is about $1,000 out of pocket in expense for one test.
Yes.
So artificial intelligence has a lot of potential in the areas that you've been talking about. But so far, when I read, say, Google claiming all sorts of health benefits to their AI, there have been, to my knowledge, no clinical trials of any of the claimed benefits. So how do you plan to incorporate, I'll say, rigorous science in your evaluation of AI?
Yeah, great question. I think this is early on in terms of trying to integrate some of these new technologies and new analyses with artificial intelligence and machine learning. I'd say, there are examples, and we're working with some of the folks at Harvard Medical School in particular to understand, and they've done already some great work at actually using the medical record itself and using basically an analysis with machine learning in that natural language processing to predict pancreatic cancer risk, actually based on just the terminology and words in the medical record. And so I think that's one example of where this may be useful, but I think you're right. We have not yet realized the potential benefits of artificial intelligence, and I think there's still a lot of question as to how effective it's going to be. But I think one of the values with those types of technologies and techniques is really at integrating and taking large amounts of data and being able to identify patterns that wouldn't be identifiable in just a single person looking at that data. One good example actually in our group is looking at mammograms and looking at artificial intelligence to do basically analysis of the mammograms and predict future risk of breast cancer based on the mammogram. That can't be done, by a radiologist looking at it, but really the patterns that are imperceptible to us. And so I think those are some of the early signs of artificial intelligence. But I think you're absolutely right. We need better trials, better ways to use that technology.
Okay, just amplify that. So let me just make my, I'm also a reviewer for the National Cancer Institute for grants. And so I can tell you that the honeymoon period for AI is over. So when we see AI as the dominant theme for the grant, it's a lot of sensation. So we need preliminary evidence, first of all. So unless they are able to procure that, they won't necessarily score on it. It's a means to an end. It can certainly be a tool. Okay, so I think that's important, but I don't know if it's necessarily the centerpiece and will be the solution. But there's certainly downstream advantages.
Thank you for saying that.
Yes, sir.
Question on primary care physicians and the shortage of them. Where, to what degree is that shortage of primary care physicians contributing factor to the difficulty of early cancer detections, where a primary care physician might hear the patient say something that triggers something with the primary care physician that the patient isn't even aware of?
Yeah, so thank you for the question. It's an important one. There is a shortage of primary care doctors in the United States, and we're certainly seeing that in our own community, trying very aggressively to recruit primary care doctors to the MGH. And I think there's also writ large a shortage of doctors in the United States, and there will be a shortage of general surgeons in the next 20 years. So we have to do whatever we can to actually facilitate the continued sort of pipeline of people interested in medicine going to medical school. I think that the practice of medicine is changing, and we have to change with the times. But one of the things that I worry about is the amount of virtual care that we're giving. I think that we have not studied very, very well the outcomes long-term of doing virtual care. We did it over the course of COVID because it was a necessity. We couldn't bring people in person. But I worry a lot about two things. One is, are we listening to the patient? The patient will tell you something today that will actually be important tomorrow or the next week. I can tell you that when I see patients in my office, I don't open the computer because I think that is distracting. We've become a society where we walk with cell phones, we talk with cell phones, we eat with cell phones, and we don't listen to one another anymore. So I actually think that I'm a big proponent of going back to some of the basic skills of being a doctor, not just in primary care, but in medicine in general. We have to listen to the patient, not be so focused on the technology in front of us that we have to use to document the encounter, which I think is important. But the other thing is that I think that we have to understand better what care can be delivered remotely and what care needs to be done in person. What is the role of the physical exam in how we care for patients? Because I think that what you saw today is actually the future in terms of early detection for cancers that today we don't do a good job detecting early. But I think that even in that space, in the space of detection today, we probably end up missing some opportunities in individual patients that actually told us something that was a symptom of early disease that was missed and embedded in that medical record that doesn't become obvious until a few weeks or months later, where it actually is of significant impact.
Well, yes.
This is actually a more personal question, just because I'm curious. Having done many years ago, are you seeing any change in the cancer rate that comes in with women who use IVF in trying to establish a family? And what are your results as of now? And, you know, with all these women now using that as a method to have their families and abortion coming in on top of that. I want to see just out of curiosity, as I say, what's happening.
I can actually answer that. I mean, you know, I do oncologist. So, you know, there are data, I would say high quality data that show that there is no increased risk of ovarian cancer with IVF. Especially, we were very interested in cycles of IVF, and there doesn't seem to be any correlation with IVF intervention and risk of ovarian cancer. The confounding feature is endometriosis. Women that are infertile sometimes are infertile because they have endometriosis, and there's a strong association between endometriosis and increased cancer of the ovary risk. So it's confounded maybe in the IVF story, but IVF per se doesn't seem to be associated with higher risk of cancer. We are seeing younger women coming in with ovarian cancer and other cancers. And I think that speaks to probably a larger issue. I don't know if it's environmental, but we're certainly seeing younger patients in general coming in with cancers. But to my knowledge, there's no link between IVF and ovarian cancer risk.
Yeah, I didn't have the exact statistics, but that is true.
I can also just speak briefly to breast cancer risk with IVF too, because of course we think about the hormones and the exposures there. You know, in general, there's not been a clear increased risk of breast cancer with IVF. We really think about breast cancer risk as being a more chronic exposure to hormones rather than the more short sort of bursts of hormones that are often used for IVF. And so I think from a breast cancer perspective too, there's not a big concern for the increased risk there.
Thank you.
Yes, we have a question in the back.
This question is more about cancer screening. Do you think the whole purview of cancer screening should be outside the medical system? You have a shortage of primary care physicians, and you have a lot of testing in specific risk groups which you can use AI to predict. So this is a question that I have. What are your views on that?
So do you mean when you're saying outside of medicine, more at a sort of global or sort of national level? Is that what you are?
No, in general, like a population which is about 50. If they can't access primary care physicians, should they be doing cancer screening on their own outside the medical system? That's fine.
I see. You know, good question. I think we've identified obviously the concerns and the you know, need for more primary care physicians. You know, I think the primary care is essential though in a lot of aspects of cancer screening. And as we think about tailoring as sort of that paradigm that I mentioned of tailoring the cancer risk with the screening, I think that becomes a harder thing to institute outside of a medical setting. But you know, I think as we see with some of these newer tests coming down the line, these are being offered to folks outside of the clinician's office. And so that is, I think, a challenge that we're seeing. And you know, I'm not sure exactly what the best road is for that. I think we need to see going forward. I do worry about you know, the cancer screening tests and how to interpret them is often not just a positive or negative, but you need that interpretation, which is an important aspect of the primary care physicians or, you know, clinics like ours too. So I think that that's a part of it, but thinking about it broadly, you know, we do really need to increase the compliance and also the cancer screening, I think, across the country. And so thinking out of the box ways, which I think you're getting to, I think is also important here.
Yes.
Just briefly, and I'm currently on service in the hospital, so this is fresh when I teach my trainees. So if you order a test, if you're gonna do something about it, right? If there's a mechanism, a path forward with those results. So yeah, you can do your direct to consumer, but if there's still some bottlenecks in how do you get access, right? Particularly in outside Boston's not a problem, but in other areas, then again, that's not the solution, right? We need to kind of, it's more of a systems change. So make sure you order a test that's going to change management. It's going to actually lead to something tangible and not just be stuck, with a test that's difficult to decipher and just very stressful overall.
I think we'll take one more question and then we'll go ahead and break for the reception.
With everybody's lifestyle changes, and I think I heard you mention sort of wellness and healthy habits, I think you have a whole segment. I think it's talking about the rabies who might be doing this. And with the study of hormones and cortisol and stress, what that just seems to drive more, with the autoimmune system and a lot of strain. And I guess with this early detection, it's maybe there's no question, but I think it's more a comment on how important primary care doctors are.
Yeah, no, I would absolutely agree with you. I mean, I think, it is looking at the whole person, not just, one particular cancer risk. And I think integrating, aspects of lifestyle medicine and some of the things that you described, stress related factors. I think all of those really do contribute to overall health outside of even cancer. And I think we're understanding and learning that better, but it is going to require primary care doctors and other specialists to support patients that are getting through.
There was literally an active grant funding call by the Department of Medicine here at GH for new technologies for screening for primary care settings. So I think it even speaks to we need to decentralize whatever materializes happens. It's about empowering still that primary contact with patients.
Yeah, I'll just say that I had 4 decades of Johnson.
You don't need to say any more. I think all of us know John Goodson, just remarkable. So first of all, I'd like to thank Dr. Castro, Dr. Del Carmen, Dr. Micalizzi for really just terrific presentations this evening. And just remind you that they'll be circulating during the reception, so please take advantage of their presence. And thank you again for coming.